Dr. Amalia, I think the floor is yours.
Thank you, Khalid. Hello, everyone, and it's my pleasure to be here. I see a very diverse group of people from all over the world, and I would like to say thank you, my friend Khalid, for inviting me to moderate today's session. So let me introduce myself first. I'm Amalia Sargsyan. I'm a medical oncologist from Armenia. I practice in Yerevan. I work at the Olian Oncology Center as a consultant oncologist, and I'm research physician at Immune Oncology Research Institute, and I also was recently appointed as the head of sarcoma service at the clinic. And here, with my colleagues and friends, with Khalid and Miriam, we are hoping to have a very nice discussion on how to bring those clinical low middle income countries and how to navigate these challenges and what can we do, share our experiences and hear what your thoughts and your concerns, because also someone from low middle income countries, we started a few years ago. Only when we first went together to US, we were having discussions with different people who were having all those fancy drugs, and we at first we might think that it's not what we can do at our practice, but I can assure that it takes only a few people to make a change. And now we at our clinic already have access to clinical trials, which are with novel drugs. And hopefully today we're going to discuss more in depth. So it's the thanks AORTIC for having me and a very nice series of webinar in methods in oncology. And I know that you have two very famous people already. Most of the people here know, but let me once again introduce our speakers. The first talk we will hear is from Dr. Khalid El-Bayri, who is a research fellow in academic oncology with a focus on ovarian cancer research, evidence synthesis and research integrity at the Faculty of Medical Sciences of University of Mohammed Polytechnic in Morocco. He has authored more than 65 peer-reviewed publications and research dedicated to ovarian, gynecology cancers, and biomarkers. He is a member of ESMO, AORTIC, ASCO, and is passionate about educating medical and PhD students on evidence-based medicine and clinical research methodologies and publishing ethics and integrities. So basically, his research interests will be a focus of our today's talk. And Khalid, I think without further ado, I'll give the floor to you.
That's great. Thank you so much, Dr. Amalia. It's very nice to see you all here. I met Amalia in the United States last year, and then we developed very good professional relationships among great oncologists and cancer researchers around the globe. And to date, we are still collaborating together. So thank you so much for introducing me. I believe that you are seeing my first slide, right?
Yes, we do.
Great, great. So today I will be discussing something unusual that we don't discuss frequently when discussing clinical trials. So it will be about the concerns and the methodological flows related to randomized controlled trials in oncology. You know that this field is not perfect. There are a lot of abnormalities in the design of studies, in the reporting as well. So today I will be discussing in 30 minutes a little bit the first, let's say, the visible part of the iceberg, because there are a lot of things we can't discuss today because of time, but I do my best to summarize most of them. So these are my conflict of interest disclosure. This is very important to be reported at the beginning of my slides. Sometimes I share my opinions, they are my own, and they do not really reflect the vision of the AORTIC, of the affiliation I am currently working with, but you will rarely see my opinion. So every slide should have evidence in every statement. So let's ask something, a basic question when you are a cancer researcher or when you are practicing oncologists. So you always ask yourself, what are randomized and controlled trials designed for? What do we need to achieve in terms of the outcomes we need to deliver to patients? So basically, there are primary endpoints, primary objectives of all the research we are conducting in terms of clinical trials. The first thing is overall survival. So patients need to live longer, but not just survival. It's the quality of survival that matters. So we need also to have better outcomes in terms of living better. So we are talking here, of course, about quality of life. So the question in related to this currently, is it really the main aim of randomized control trials? Are we really improving over survival? Are we really improving quality of life? And of course, are these randomized control trials really truly delivering their intended benefit or intended promise? So this is basically the main aim of my slides with you today. And I will be very happy to take questions at the end of my presentation. So these are a little bit some of the points I would like to attract the attention to today. Maybe it will encourage your common sense use in your daily practice and also when designing research. So I will be talking about some issues related to randomized controlled trials, particularly what are the good standards of designing them, of reporting them. Also, what are the issues related to sometimes bad randomized controlled trials that bypass phase 1 and phase 2. We are seeing a lot of randomized controlled trials, unfortunately, without a rationale from phase 1 and phase 2, which is not ethical at all. We need also to talk about the primary endpoints of good randomized controlled trials, but we are seeing a lot of, let's say, surrogate endpoints that are not really correlated with primary endpoints. They are used as primary objectives, which is not really something we need to encourage. I will be talking also about sub-control arms, informative censoring, and the reporting of toxicities in clinical trials, some concerns regarding post-progression therapies that are not really offered to patients, and then some results that are considered high level, but unfortunately they come just from post-hoc analysis that is implanted, and also some issues related to subgroup analysis in randomized controlled trials. Then, of course, discussing a little bit the statistical significance versus the clinical relevance. There are a lot of randomized controlled trials that are significant statistically, but they do not really offer any benefits to patients. Why they are approved? This is one of the biggest questions we need to discuss today. And then, of course, the conflict of interest of oncologists in related to industry. Why do we still see ghostwriting in oncology trials? And of course, the role of social media is also very important to be discussed today. So let's just go back to our maybe undergraduate courses we had while we were getting our training as future medical doctors. So we all remember that always our professors says that you need to remember that the high level of evidence is always coming from randomized controlled trials and their meta-analysis. The issue is that, unfortunately, there are a lot of randomized controlled trials and meta-analysis of randomized controlled trials that are considered as a high level of evidence according to the statistical design, according to the knowledge we have to date in terms of designs of studies. But unfortunately, because of the bias, because of the reporting, the under-reporting, because of a lot of issues that are seen currently, particularly in industry-sponsored trials, we are no longer trusting level 1. So it's a big issue now in oncology, and I will be very happy to attract you to these issues so we can discuss them together. So it's not, as you know, it's not always about the type of the evidence. It's also the quality of the evidence you have. So you can have a lot of great randomized controlled trials, but the quality of the evidence they provide to practitioners and to people who develop guidelines is not really that good, so you can use them to make decisions in your daily practice. So as you know, critical appraisal of studies, not only randomized controlled trials, but all studies in medicine is very, very important. You should not just trust the type of the study. You should not just trust a study just because it's published in high impact journal. So there are a lot of factors to be considered when reading and criticizing the studies in oncology. So this is basically something you already know. When you want to develop a trial, of course, in case of randomized controlled trials, there should be always an experimental group. There should be always a comparator that is control. There should be randomization. There should be comparison. There should be primary endpoint. There should be secondary endpoints. The problem in this design is that you can manipulate some of the steps, so you can show positive results, unfortunately. You can manipulate some of the designs to make your results appealing, more interesting. But unfortunately, it's not the case in all trials, unfortunately. So I can tell you just a little bit about this very interesting slide. For example, when you design a new study, is it really answering real questions coming from the real world? Because we are seeing a lot of trials. It's called the Me Too story, which means that you have a lot of clinical trials answering the same question. Sometimes you don't need a new drug. You need a better drug. You need just to do the study correctly so you can provide evidence, instead of doing a lot of trials with flawed designs and then have a lot of drugs approvals for the same intervention, for the same setting, is not always a good thing. So also, in the current landscape of trials, we are seeing a lot of control arms that are not appropriate, which means that instead of comparing with standard of care, at least you are comparing with sub-control, which means that you are designing a study to show superiority or non-inferiority because your control arm is substandard. It's not really something we use in practice as high standard for for practicing. There is also a very important parameter to be used. It's called informative censoring. So in some trials, there are particularly those trials that use progression-free survival and other surrogate endpoints as primary endpoints. So in these studies, there are some patients that may drop out from the study, and you can show easily statistically significant results just because of the dropout, not really because of the effectiveness of or the efficacy of the drug. So this is something called informative censoring. We are seeing it a lot of times in study designs, unfortunately. Sometimes you use some surrogate endpoints that are not really positively correlated with good evidence with overall survival. So you show, for example, improvements of progression-free survival, but after later follow-up, we have good data, matter data, there is no improvements in overall survival. So it's not really that good to use sometimes progression-free survival as an endpoint that may replace overall survival that is the primary aim of doing a trial. There is also, unfortunately, the reporting of the finding that may be biased because some trialists, I can say, because they work with industry and they are sponsored by pharma, they may not report better enough the study finding they have. So you can show a lot of toxicities in your trials, but are not really reported optimally in the study report. So there are a lot of toxicities are hidden, or you need really to look into the details so you can understand if really there are some grade 4 events that are very, very serious, or you use some language that is really optimized to show that toxicities are manageable, but when you look into the details, it's not really that manageable. It's very, very serious. And of course, sometimes you show a lot of improvements in terms of statistically significant results, but when you see the real value of those results, they are not clinically meaningful, which means that there is a small group of patients that may benefit, but not really the study population you studied your intervention on. So this is very, very important to be known. So starting just from this slide, you can a little bit predict what I'm going to discuss in the upcoming slides. So this is very important to be known. We have a lot of phase 3 trials of solid cancers that bypassed phase 2, which means that we are exposing a lot of patients to maybe ineffective drugs without preliminary evidence, because you need phase 2 to show at least preliminary evidence before you go to phase 3. In a lot of trials currently, unfortunately, you don't have that. So it's really unethical, and it should be avoided, particularly in academic trials. So the pooled progression-free survival, for example, hazard ratios or for phase 3 trials that bypassed phase 2 were shown to be worse than phase 3 trials launched based on positive phase 2 evidence. So there is, as you know, steps to be followed, and if you don't really follow them, you may expose and harm patients with drugs that may be more toxic than effective in terms of outcomes. So this is very important slide we need to discuss as well. So this is a trial, phase 2 trial that compared chemotherapy with toripalimab, which is human checkpoint inhibitor, compared to chemotherapy alone with placebo. So it showed some statistically significant result with an interesting hazard ratio of 0.67. But when you go into the details, the median progression-free survival gained from this new human checkpoint inhibitor in addition to chemotherapy is 2 weeks, really 2 weeks. So it's nothing, really nothing, but it's statistically significant just because the study was maybe powered to show that statistically significant results. But when you go to practice, it's not really clinically relevant. So we are seeing a lot of these kind of studies published, unfortunately, and maybe some patients, sometimes they come to you and they say, I want that drug, I want that drug. But when you look into the detail and you explain to them, you show easily that it's just improvements by days, not really some improvements that will encourage doctors to prescribe those treatments that may cost a lot to patients and their families. So this is why we need a lot of appraisal. So ESMO currently is doing very great. They developed the tool, I believe that you already know about it. It's called ESMO MCBS. So it really assesses the quality of the studies in terms of all of these primary endpoints, quality of the evidence, etc., to tell you if really you need to go further and prescribe or not. So I really invite you to have a look at this great tool because it tells you in terms of quality of the evidence you have. And I'm very happy to have some colleagues who worked on this working group who are really doing great job for ESMO currently. So this is another example of what I call sub-control arms. So this study compared a human checkpoint inhibitor, which is pembrolizumab, with axitinib in renal cancer. And of course, this addition, this combination increases the cost for patient and also the toxicities. So it was compared to sunitinib, which is another anti-angiogenic. So axitinib, sunitinib, they belong to the same family, but they are not the same in terms of efficacy. So instead of comparing pembrolizumab, axitinib versus axitinib alone, they compared it with sunitinib, which is not a good control. Because if you want to show superiority of a new drug, you need to have a good comparator. Here, in this case, it should be axitinib, not sunitinib. So unfortunately, we are also seeing a lot of these studies published in great journals. To be honest, you need to be very careful while reading studies published in the high impact journals because of conflict of interest. So this is one an example. And of course, this is something called subcontrol arms. Sunitinib, is not the good standard of care to be compared with. So we are seeing a lot of studies having this issue, unfortunately. And of course, with the rise of industry-funding trials, as you can see here, there is unfortunately and it's unethical, very bad to see that the primary objective of oncology, which is overall survival, is being non-used or not used as primary endpoint. Instead, when you have more industry-funding trials, you have more use of progression-free survival as primary endpoint. Why? Because you can get the results sooner, so you can get the approval and get the money back from the trial and also benefit from this for-profit data. But of course, why not overall survival? Because if you use overall survival, you can have a better answer to your question. So progression-free survival, unfortunately, in the last decade is being used a lot more than normal by industry sponsored trials. And sometimes, not always, it can lead to better treatment for patients, but not always, unfortunately, because it's rare currently to see good correlative data with overall survival in studies. So remember, always, what is primary endpoints we need to use in randomized control trials for oncology? We have one aim first is to help patients live longer and also help them to live better, because sometimes you improve their survival, but their quality of life is not really that good, so they can really benefit from the treatment they are taking. So here, of course, we are talking about two primary important objectives that should all trials have, which is overall survival. We see it a lot in studies, it's good, but unfortunately the quality of survival is not seen in a lot of studies, so we don't know if the toxicities are impacting the outcomes of patients or not. So I really love this slide. It's not mine. I took it from one of the greatest presentation of my professor, Professor Ian Tannock, for educational purposes. And he really showed beautifully that when you have a planned flawed study, you will always profit for sponsor. So it really tells you that this is a real PFS. Why PFS is being used by pharmaceutical industry sponsored trials. So unfortunately, progression-free survival, as you know, is commonly used as primary endpoint in cancer clinical trials, assessing novel drug treatments. It is considered as low threshold. We all know that. We all believe in that. And as a result, you know that it's available sooner than overall survival. But later, when you don't collect information about overall survival, you cannot tell people if really patients are benefiting from that or not. So, however, as you know, progression-free survival is rarely a surrogate. So we have few studies that are good to show this kind of surrogacy. So progression-free survival can be biased if there is informative censoring. This is what I told you in the beginning of my slides. This is another example where we showed that there was improvements of progression-free survival in this trial that investigated apelezib for hormone receptor positive advanced breast cancer in combination with fulvestrant. So when you had your early data about the progression-free survival, you showed greatly that there is improvements in terms of progression-free survival. They are really clinically relevant here, as you can see, very interesting hazard ratio. But when we waited until the data of overall survival are mature, they are published, we didn't show any difference. So this means that if you consider progression-free survival always as primary endpoint, is not ethical at all, because you are exposing patients to a lot of drugs that may not be effective for long term. So this is another issue I would like to attract your attention to. It's called post-progression therapies. You know that when you enroll a patient into phase 3 trial and they progress under new treatment, you need always to find a solution for them, not just asking them to leave the trial, because you need to find post-progression therapies. Unfortunately, we are seeing a lot of studies, particularly conducted in LMICs, where patients progressed under new intervention, new drugs, but there is no post-progression therapies offered, which means that you are just letting them go without offering any standard of care. So this is seen in a lot of trials like Monarch, Natalie, Kynot, 564, and it's seen currently. So it's a huge issue because it's not discussed a lot in bigger conferences, because unfortunately in a lot of studies they do not allow crossover, which means that when patients progress they don't have anything to offer. They even don't ask them to go to the other arm to benefit from the crossover treatment. There is also this very important issue that is not ethical, and you need to consider it seriously. There are a lot of people discussing the importance of the data coming from subgroup analysis. So if subgroup analysis was not pre-planned, it doesn't mean anything. It's post hoc, which means that it's until you have the data that were collected to answer clear question about the efficacy of your intervention on the ITT, on the intention to treat population, then you conducted some other analysis to see if there is some benefit from some small groups who might benefit or not. So when you make recommendation based on post hoc analysis or subgroup, it will not really give good standards, good evidence for clinicians to consider those data. So you need always to consider ITT information, ITT data, and then subgroup analysis, just a way to understand better. It's not based on that you are going to make recommendations. So to date, we are seeing the same reasoning for RCTs. We have also a lot of biomarkers coming from post-hoc analysis, and people are now recommending new treatments based on some biomarkers, but the biomarker was not pre-planned at the beginning of the study, so it's not really high quality evidence. Because again, when you go to the diagram of evidence-based medicine, you will tell me this is randomized controlled trial, this is good data. But again, the biomarker used in that trial, was it really pre-planned or not? If it was not pre-planned, this doesn't give you the right to use it as a clinical decision tool. The question is, are really the current randomized controlled trials mimicking what happens in the real world? No, of course, no. We are seeing a lot of randomized controlled trials are selecting patients with specific inclusion criteria that we don't have in the real world. So this means that you are going to show some positivity in your results, that it might benefit a small group that has strict inclusion criteria. It's not something you are going to see in your practice. So it's very, very bad. You are recruiting more patients with younger age, with high performance status. You don't really enroll patients with comorbidities. So at the end, also, you have underrepresented populations are not enrolled in trials. And when you go to the real world, it's not the same population, unfortunately. So you cannot really talk about efficacy and effectiveness. It's old, but gold. This is very nice slide I love. It's a study that tried to see if there is any concordance between the median overall survival seen among patients treated for metastatic castration-resistant prostate cancer, treated with docetaxel in trials, compared to those treated with same drugs in the real world. And of course, the overall survival was shorter in the real world compared to trials. So, for example, in addition to this, real-world patients developed more febrile neutropenia than in trials, which means that there were more selection bias in those trials that selected only patients they might not develop more side effects and adverse events when they're exposed to these new drugs. This is old, as I said, but good because it tells you what happens in other trials. I still have 5 minutes to finish my slides, so I believe there are other interesting information you need to know when you want to uprise clinical trials, particularly randomized controlled trials. So this is another real-world evidence study that was conducted in the US based on the SEER database. It's already thousands of patients to see if the hazard ratios that we're seeing in randomized controlled trials are at least nearer to what was seen in the real-world evidence. But unfortunately, it was not the case, which means that we are amplifying a lot this effect size, in randomized controlled trials compared to the real world, and why we are excluding a lot of patients and really restricting inclusion criteria. It's just because you need to have greater and beautiful hazard ratios, not really to benefit patients. So it's not ethical at all because what we need to see in clinical trials should be also seen in the real world, but it's not the case. So we have this lack of generalizability currently seen in a lot of trials in oncology, and unfortunately, a lot of recommendations are based on this kind of studies. So again, I really invite you to think seriously about real-world evidence, because in low-income countries, we don't publish our experience with new interventions, with new trials, with new drugs. We have medical records there, we have information about toxicity, survival, but we don't publish that. So please think seriously about publishing your real-world evidence, because it tells more if we are really conferring or benefiting patients from these advances or not. So population-based studies now should also be considered as a way to find evidence. It's not just randomized controlled trials and meta-analysis. We need to find concordance between the two if we want really to make good recommendations. So we don't need just real-world studies. Yes, we need high-quality real-world studies. This is very important, because publishing a retrospective study does not mean that you are doing very well. Publishing them is good, but you need to respect some guidelines. So fortunately, not unfortunately, ISMO developed some very, very good tools and guidelines to help clinicians to publish better real-world evidence. And it really shows that how real-world evidence can be used in making recommendations in decision-making as complementary information to randomized controlled trials. So have a look. It's really interesting. I love this slide, and I did a lot of research in this direction, even with some colleagues from the IDEA Award. Last year, we discussed the conflicts of interest among oncologists as an oral abstract at ESCO 2024, and we showed that there is a lot of influence of industry in the medical practice. So one of the possibilities of this influence is called ghostwriting. So what is ghostwriting? So basically, when an investigator is a primary investigator of a study of randomized phase 3 trial, for example, he needs, or their team, they need themselves to report the finding of their trial. It's them to write the article to be published in the journal. It's not pharma. But unfortunately, pharmaceutical industry are now recruiting medical writers so they can write the reports of these trials to show some more positive results, to optimize toxicity reporting, etc. So they can show that they did great. But when you look into the details, there are a lot of issues in those studies published in great journals. So again, it's investigators, it's oncologists who were treating patients in those trials who should write those reports, not pharma. Why pharma? Because they say, okay, we want to make these reports published faster because we need more evidence, we need more data, so everyone can benefit from that. No, it's not the case. You need quality evidence. We don't need just articles published in famous journals. We want good data written by experts in the field. But unfortunately, we are seeing a lot of ghostwriting. There are a lot of abstracts communicated in great conferences that are pharma sponsored. They tend to show more and more positive results, and it's called reporting bias, which is very bad for science, but unfortunately it's very, very hard to mitigate, even if you increase transparency by asking for everyone to share their conflicts of interest widely. And of course, there are also this issue with honorary authorship, which means that you are offering positions in studies, in articles, maybe even if they don't really participated actively in those trials. So this is also something bad happening in science, but it's not me to resolve it. My take-home message is at least to encourage increasing awareness and transparency. And it's something really seen in low-income countries. The practice of oncology in RMICs is heavily influenced by pharma, but we don't have at least good reporting of these interactions. But in the US, for example, there is transparent database where you can find all the interactions of oncologists with pharma. So it's something we really need to implement in Africa, for example, and other RMICs. So this is this something interesting too. It's an article published in JAMA where they show that there is an increase of medical writing when you have more trials that are funded by industry. So the question is, why are these randomized controlled trials investigators not reporting the finding of the studies themselves? Why they need someone else to do it in their place? It's them who did the study. Why asking for someone else to do it in their place? So there is substantial potential for spin and bias that could favor the sponsored product. Do never forget what I said you in the slide presented by Professor Ayan Tanuk. Progression-free survival means for profit for sponsor. This is what it really means. So this is a study I presented last year at ASCO, where we showed that unfortunately there are very few oncologists in LMICs that understand what is industry influence. I mean, they have interactions with pharma. They receive honoraria, they receive gifts, travel grants, but for them it's just something easy. It's normal. I mean, it's okay to receive these kind of things, gifts, etc. But it's not really that good in terms of ethics. So it's not reported. That's the first point. The second thing, it's bad to see that most of oncologists in a lot of regions of the globe, they don't understand what is a conflict of interest. So it's something really we need to fight for, and this was just the beginning of a field that I am currently interested in, which is research integrity, where I am currently doing a lot of research related to this kind of interactions. So again, there is famous people from some colleagues from Africa, particularly my colleague, Dr. Fidel Robagomia, who wrote a great paper at the Lancet Oncology. And I really invite you to go have a look at that study, at that paper, because it's really, really nice one that really describes very well this issue, this market of interactions between pharma and oncologists. Again, I am approaching to finalize to finish my slides. So the role of experts: be careful of social media. There are a lot of oncologists working with pharma on social media, trying to make some marketing for a lot of studies. But believe me, if you look into the details, it's not always the statement they make. These are just two examples of statements I took from social networks that shows really that it's a big issue. So there are some oncologists that may say, this is great study. This study that showed improvements of progression-free survival by 2 weeks is great for patients. It's interesting, it's great, it's innovation. But when you look into the experts' profile that criticize these studies, they will tell you the truth, because again, it's using drugs that cost ungodly sums of money that benefits almost nobody. Because improving survival of patients with 2 weeks doesn't mean anything really to you, to your family, to the family of patients, etc., to patient advocates that are maybe with us today. So the question is, why are some drugs not delivering the promise? Because we have a lot of flawed study designs, we have the role of social media, we have a lack of good training of oncologists to apply RCTs. I just finished the course for medical students here in our university, where we are trying to tell them the truth about medicine. We are trying to expose them early to research, to the good appraisal of studies, so they can at least understand what is good, what is bad, when reading studies that may be used in their decision making one day. And of course, the role of expert is key in some papers. Also, you can see some patients coming to you to say, why not prescribing this drug for me? I saw it published in great journal like here, and when you go to the details, it's just one patient who survived better with the new drug. You cannot make generalizability for that, because it's just only one patient. You cannot really tell the truth about it. So always remember, this is my last slides. Subcontrol arms are bad. Statistically significant does not mean anything. It should be clinically relevant. There are a lot of studies having implants, subgroup analysis. Progression-free survival as primary endpoint is not that good. Absence of post-progression therapies, a lot of informative censoring. Be careful about this, because it may hurt your patient. Go to this paper I published recently, where you can have at least some ideas about how we criticize clinical trials, in this case of platinum-resistant ovarian cancer, where we objectively assess those trials. So you can have at least one answer to a lot of questions about the use of some treatments in platinum-resistant setting in ovarian cancer that really do not benefit anyone. So these are my slides. You know that we want pharma not to disappear, because they are benefiting our patients. They are doing great science, publishing great studies, but they need to take care of what they are producing. So we are asking them ethically to change their mindset, because again, we are hurting a lot of patients. So they should not bias medical writing. They should not manipulate trial results. They need to do better reporting of toxicities, etc., etc., etc. And of course, what I discussed with you today is just the first part of the iceberg. There is a visible part of it where are a lot of problems, a lot of issues that are damaging the field of oncology and also patient care. And I am inviting you to look at this great initiative from CSO. They are really training good oncologists to be good in their practice. Have a look, it's great. They have a lot of training material. It's up to you to decide whether to be patient-centered or not patient-centered. So thanks a lot for listening, for this opportunity to discuss with you, and I will be very happy to take the questions at the end.
Thank you, Dr. Khalid, for trying to concentrate all of this data in only 30 minutes. You spoke on inferiority arms, on the integrity, on the conflict of interest. All of this matters a lot, and I believe we will have a lot of questions, but as a matter of time, I think we'll take them to the end. And I love the comment and you were mentioning. So people we see from somewhere around. I had the pleasure to meet Dian Tanak, and his ideas are indeed very important, very patient-centered. We will have a discussion on later. And now it will be my greatest pleasure to introduce my another friend and a colleague, Dr. Miriam Saadi, who is an assistant professor of medical oncology at the University of Tunis, Selman, Faculty of Medicine of Tunis Abderrahmane Mami Hospital in Tunis, Tunisia. And she will be speaking on the role of adjuvant CDK4 inhibitors. Indeed, with this latest indication of CDK4 to a lot of patients, it was maybe easy for high-income countries, but a lot of low-middle-income countries struggle with this new indication because they're expensive, and we're gonna see when what to do, pros and cons. Please, the floor is yours.
Thank you, Amalia. So we're talking about adjuvant CDK4/6 inhibitors in breast cancer, pros and cons, just after Khalid was criticizing clinical trials methodology. Here are my disclosures. So first things first, let me remind you and us, everyone here, that HR-positive breast cancer is well known for a late relapse. So more into 7 or 8 years after the diagnosis. And even 20 years in this meta-analysis published in the prestigious NEJM, a meta-analysis of 88 trials, including more than 60,000 women with HR-positive breast cancer, early breast cancer. And the risk of distant recurrence was strongly correlated with the original tumor size and lymph node status. So the rationale, if I may say, because Khalid said we don't say rationale of adjuvant CDK4/6 inhibitors, is that with the risk of late relapse in the HR-positive breast cancer, we now prescribe endocrine therapy for 7 to 10 years. And we have seen the proven benefits in overall survival of CDK4/6 inhibitors in metastatic breast cancer. So maybe why not in the adjuvant setting? We want our patients to not relapse at all, like even after the 7 and 10 years of endocrine therapy. We want our patients to be cured. So 4 major trials have been randomized clinical trials have been published to evaluate CDK4/6 inhibitors in early HR-positive breast cancer, Penelope B and Pallas for palbociclib, Monarchy for abemaciclib, and Natalie for ribociclib. Penelope B and Pallas were negative with palbociclib, and Monarchy with abemaciclib and Natalie with ribociclib were positive in the IDFS, invasive disease-free survival. So I want to highlight here the design of these trials. Penelope B is the only double-blind trial. The 3 other trials are open-label trials. So I wanted to show you quickly the curves and the IDFS benefit in the intention to treat population in Monarchy with a delta of 7.6 in the IDFS and 6.7 in the distant relapse-free survival. And in the cohort 1, which is actually the majority of the patients and those with the worst prognosis, 90% of the patients were in the cohort 1. And by poor prognosis, we mean they had at least 4 positive axillary lymph nodes, which later in the study were stratified in 2 categories, 4 to 9 or 10 or more positive axillary lymph nodes, or they had 1 to 3 with either grade 3 tumor or a size of at least 5 centimeters. And in cohort 1, the delta is even more important, 7.9 for the IDFS and 7.8 for the distant relapse-free survival. So this was for monarchy with abemaciclib, and IDFS in elderly, we have a delta of 3% and still statistically significant. For RFS and DDFS as well, recurrence-free survival and distant disease-free survival with hazard ratios of 0.72 and 0.74. Both trials were negative for overall survival. And Khaled said in his slides that PFS shouldn't be surrogate for OS, but is OS suitable for diseases that advance slowly and has long-term survival? We are talking about early breast cancer. I mean, we don't want events to happen, so maybe overall survival is difficult to show benefit here. And it has been proven that they both improve overall survival for metastatic breast cancer, where the disease advances rapidly. So a lot of studies and a lot of articles have been published to critique these studies regarding their design and uncertain benefits. And we chose to talk about this article published in the GCO from Ian Tannot. You were just talking about him, guys. So he mentioned a few points that we will review here. First point was the toxicity of treatment. The toxicity of treatment led to interruption of the treatment due to adverse event in more than 60% of the patients in monarchy, so with abemaciclib, and 31% in NATALY with ribociclib. It's much more in monarchy because of the diarrhea, I guess. And in NATALY, 31% is actually 6 times as large as the 5% who stopped ribociclib because of an IDFS event. He also talked about the financial toxicity, which I put here in numbers with many zeros. It's $300,000 for adjuvant abema and $500,000 for ribociclib. We are talking here in US dollars. So I let you imagine the numbers and how many zeros in our currencies in low and middle income countries and in Africa. The second point was a failure to provide optimal post-progression treatment to control patients, which is actually a major deficiency in trial designs, especially that 27% of participants in monarchy were from middle-income countries, where, as you were saying, Amalia, accessing a CDK4/6 inhibitor would have been difficult or sometimes impossible. So this biases overall survival curves in favor of the experimental treatment. And it hasn't even been reached. I mean, even with the bias that is supposed to favor the experimental treatment, it wasn't favored here. Third point is the high prevalence of censoring. These are open label trials. So in the control group, participants know they are not taking the treatment. So they might drop out because of decreased interest or to seek alternative treatments, especially once they have progression of disease or recurrence of disease. Here we are talking about early breast cancer. And in the experimental arm, patients will drop out because of poor tolerance or because of recurrence. So we will find ourselves with a selection of patients, with a selection of patients with poorer prognosis in the control group and better prognosis in the experimental group, because patients who will stay in the study are those who tolerate well and who respond. This will lead to a confounding of the original random assignment. There's no randomization anymore somehow. And this will bias results in favor of the experimental group. So here we are talking about the IDFS benefit, not the OS, like in the previous point. And in this table from the same article published in the GCO, he reports numbers of patients censored compared with numbers of events. And in monarchy trial, 8 to 9% of patients or participants were censored for IDFS, and 9 to 10% were censored for OS. And we don't know what happened to these patients. Is it recurrence? Is it death? Is it because of the treatment? Is it because of the disease? Is it because of something else? And this delta in the intention to treat population and in the IDFS is less than the number of participants for whom this endpoint is unknown. Let me take you back here. So it's 8 to 10%, and the delta is 7.6%. And then he put this reference because a sensitivity analysis has been done in which the IDFS curves were adjusted for censoring. And it showed a loss of significant difference between experimental and control curves. So we don't have the IDFS benefit anymore once we adjust for censor. Excuse me. Once we adjust for censoring, we lose the benefit in IDFS. One of the last points he mentioned was that the CDK4/6 inhibitors may accelerate development of endocrine resistance, which we don't want for our patients. We want them to stay endocrine sensitive as long as possible. And we want to be able to treat them for the 7 or 10 years with endocrine therapy without relapse, recurrence, or progression. This has been proven in the neoadjuvant setting in this article. So that's why we are saying it may accelerate development of endocrine resistance, but I can't figure out why it wouldn't be the same in the metastatic. I know the tumor is in the adjuvant setting, sorry. I know the tumor is not here anymore, but still some maybe micrometastasis might become resistant. And I myself invite you to check Common Sense Oncology. They published these principles for the design, analysis, and reporting of phase 3 randomized clinical trials. And among the few points on how to improve the design, analysis, and reporting of randomized clinical trials, I chose these 3 points because it applies to the CDK4/6 inhibitors trials in the adjuvant setting. So is to provide and fund optimal treatment for patients assigned to the control group in case of progression and relapse, which I remind you, it has not been done in these studies. And to indicate numbers of patients censored below time to event curves, because this will help conduct the sensitivity analysis to explore possible effects of censoring. They are really doing a great job, Common Sense Oncology team. So with this, it's the end of my slide, but is it the end of CDK4/6 inhibitors in the adjuvant setting? I don't know. Maybe we have to check ctDNA. So we introduce the treatment then. Also, the duration of treatment, 2 years for abemaciclib, 3 years for ribociclib. So why these durations? And maybe not immediately after the end of chemo or after surgery if they didn't have chemo. So maybe we should try them or test them like more closer to the 7 to 10 years after the end of endocrine or before end of endocrine treatment. So we act against that late risk of relapse. And thank you.
Thank you, Miriam, for this wonderful presentation. And indeed, it's very interesting, important topic for everyone. I believe this problem is not only for LMIC, it's also for high-income countries. A lot of government, Ministry of Health are already issuing with these financial problems. And to give something, like, can we imagine how many breast cancer patients are there everywhere in the world and how many of them will need this treatment? So if you're trying to provide it, you need to justify it. So I love the comment on maybe we need something to identify better people who will benefit most. Before I invite everyone to comment and ask questions in our chat, I'll be happy to address this to our 2 wonderful speakers. Before everyone starts, maybe we can initiate with Miriam. So what do you think? You mentioned ctDNA, but how do you think we should implement about these biomarkers? What do we need to implement these therapies? Maybe we should just wait, or what are your ideas on why someone would like to do it?
Yeah, I think we can try. I love ctDNA. I think it's the future of oncology. I think it will shape how we treat, especially in the adjuvant setting. Like after surgery, patients are supposed to be cured, and if they do need or do not need the adjuvant treatment, maybe the response is in the ctDNA. So yeah, maybe we could do it regularly. I mean, we see our patients on a regular basis for surveillance with mammograms, with CT scans, and maybe we can implement ctDNA as well, so we can make sure if we are good or we need to implement that treatment then.
Well, I love that point. Actually, it was, I think, a few weeks ago when ctDNA adjuvant setting for bladder cancer was introduced. So those who had clear ctDNA didn't need immunotherapy to go up front. So sometimes we think of ctDNA to be something for high-income countries. But your point, I love that it's maybe more important for low middle-income countries because you can spare a lot of people and a lot of time. Khalid, what's your idea? What should we do so our treatments are more cost effective? You mentioned in a lot of, I don't know, your research and your
Yeah, I'm not
presentation.
a skeptic. It's just that, well,
Uh,
I don't practice oncology now. I am doing research, so I focus more on
as a
methodology.
researcher, what would you advise to Miriam when
Yeah,
she's
this is
trying to
this is
choose
what I
for
want
her
to say as
patient?
point of view. Yeah, so sometimes clinical oncologists see things differently. Researchers see things differently because we have our aims. The clinician should improve patient outcomes. We want the design to be improved. So this is my point I would like to discuss with you. So we have, of course, we have a lot of great data coming from great studies about biomarkers, about predictive biomarkers. The only issue with those data is that they were not pre-planned. There is a lot of post-hoc analysis, which means that it's until the end that you discover something, you stratified patient, you see that there is some improvement for some subgroup of patients. But again, in terms of the design of the study, in terms of statistical analysis, everything should be pre-planned. So if we have good evidence about ctDNA or other liquid biopsy-based approaches, I think, as my colleague Miriam said, it can be the future, but we need good evidence. It's not about just evidence. I mean, you will have a lot of studies coming soon, published at ISMO soon, at ASCO, but do we have good evidence to make statements, to make decisions? I think there should be guidelines to push trialists, particularly pharma-sponsored trialists, to design better studies. There is some good news. If you are aware of the latest publication, the document published by FDA, now all pharma-sponsored trials, they need to collect data for overall survival, even if it's not their primary endpoint. They need to clearly have clear vision of collecting toxicities, etc. So I think there is some progress, but we need to advocate for that. I mean, are we really advocating for change in terms of better science, or we need just better drugs because they improve outcomes of some patients? So that is the question. In addition to all of those financial toxicities, do not forget, you have better drugs based on precision medicine approaches. You need other biomarkers. So who are going to pay for those biomarkers? That is the question. Liquid biopsy needs a lot of sequencing, a lot of things. So in our context, particularly in my context in Morocco, I don't know, to be honest. I am seeing things very skeptically, but again, there should be some optimism.
Okay, I can be the optimist part. I love this. Well, I think the future is going and moving. I think a few years ago, if I see in my studies when we started, trastuzumab deruxtecan was a huge something, and everyone loved it. But when the patient was coming to clinic, it was almost impossible to prescribe to anyone because the drug was so expensive, no one could afford. But if we see from the years, it's going down and it's a few times more. Now we are having more people. The same for immunotherapy. A few of immunotherapy, the patent will expire, and soon a lot of generic companies will come there to replace it. And if we have good drugs, I think we need someone to take quality control and make good generics so more people can benefit from it. I do believe in new drugs. they really make change. But you're right. I think the evidence should be there and rational also. And Khalid, from your presentation, I also liked the part about the arms and choosing a world's arm for the control. What do you think? How to address it? And if, for example, it is designed for a different country, should the arms be different? Like because you cannot offer something else, the control arm should be the one that is standard of care in your country, or do you think it always should be the best?
Yes, agree with you. I mean, there are some rare exceptions where you cannot really apply all the good rules of doing good science. I know that in some setting you cannot consider overall survival as primary endpoint. You know, it's challenging, etc., etc. So all of this is understandable. The only issue is that why are we decreasing the bar? I mean, we should keep the bar of having something in these exceptions, but not decrease the bar for all sitting, because we are seeing a lot of sub-control arms even when you have standard of cares available. So who should resolve this? I think the only solution should be coming from regulatory agencies. For instance, I don't know what happens in Europe in terms of the EMA, but I think they are doing some good job in checking for these points. But for instance, are we doing the same in LMICs? Do we have regulatory agencies that check for the design of studies conducted in LMICs to see if these patients really are receiving post-progression therapies, are receiving not-SIB controls, etc.? Are we checking for that? Why don't we have good regulatory authorities in our regions? I think we need to fight for that. But again, as you said, in some cases it's very hard to increase the bar, but we need to think about it, at least for setting where you can compare with a good control. This is my humble opinion.
Well, I do agree. So we need to be very careful, and our regulatory as well should be very developed and be very cautious. But we really wanted to have the trials in our countries because we can give access to a lot of new drugs which people cannot buy. So Miriam, as a practicing oncologist, how do you think it would attract other people to come? What are the benefits of doing a trial in LMIC, or are they? What do you think?
Well, I think there are a lot of benefits. The opportunity itself. I mean, the result will benefit the patients and future patients and doctors and oncology. So it's really beneficial for everyone. But we definitely need those regulatory systems Khalid is talking about. I learned a lot from Khalid's presentation. We have now it's a phase 3 clinical trial, but it's an international one, and they are recruiting from our center. And after preparing for this webinar and after listening to Khalid, I'm wondering if they are ready to provide treatment in case of progression. So I will dig into that.
Yeah, true. Crossovers are very important, but it also could be a benefit because you can really check the efficacy of this drug. For in another countries, they are going crossover to another newer fancy drug, and you cannot say which actually benefited the OS most. So indeed, you're very right. Whether they will provide after progression something or not will define what we're gonna learn at the end. So the real benefit of this new drug, or just the matter of time. And what would be your idea about it, Khalid?
Well, there is something that attracted my attention in the last 2 years. I know that you all know about the SONIA trial, which is an academic study. So it's sponsored by the money coming from health insurance in Netherlands. So it's money coming from the public, from the government, and it showed a lot of interesting things. I know that it's criticizable, that study, particularly the SONIA trial. There are a lot of bad feedback about it, some good feedback from experts as well, but it's good. It's a good move, which means that if we are running good academic studies that answer local questions, which means that we are running trials not to benefit big pharma, we are running trials to answer specific questions in our setting, and it's funded by the money coming from health insurance from the government, I think we can at least provide some good evidence for these innovative drugs coming. But the issue again in LMICs, you don't have that money enough to run a phase 3 trial, randomized control trial. But I think it's a good move. If we are seeing more academic studies than sponsored trials, at least in countries that respect its population in terms of outcomes to be delivered, I think it's a good move. So in my place, I don't have the right to talk about what happens in oncology in Morocco because I left medical practice. I am now only teaching and doing research, and this is what really attracts me to the field of academic medicine. So I don't have the right to talk about what happens in the landscape in Morocco, but I can just give you my humble answer. I know that there are a lot of phase 3 trials with co-investigators in Morocco. But again, do we have information if they are providing post-progression therapies, etc., etc.? I don't know because again, it's a hidden field. We don't have a lot of transparency about it, so I don't know to be honest. But for me, academic studies should be encouraged.
Yes, and it's a very interesting point. Where can academic study be funded? Because this is the matter also for the investigator-initiated trials. No one wants to fund them, so pharma is not interested, and you somehow have to run. It's usually driven from the practice, and maybe the groups and cooperative groups can also be another option to go on with them. Another interesting point, I will encourage our audience. I see a lot of people here. Yeah, sure. To also give questions, and I'll give Mariam to you. Yes.
I may add, Amalia and Khaled. Khaled, I like the fact that you highlighted the importance of retrospective studies because we we always learn that pyramid you showed, like the highest level of evidence comes from randomized clinical trials, but we used to not look at our retrospective studies the way we should, we don't give them importance, we don't submit them to international meetings until Pfizer with palbociclib couldn't prove overall survival benefit with randomized clinical trial, and he was somehow obligated to go with retrospective studies and call it real-world data.
Yeah.
So until the West made retrospective studies sexy, as in low middle income countries couldn't make them as important as they should be. So thank you for highlighting that, and I encourage everyone here, all the participants, to publish, to do the retrospective studies, to make them real-world studies, like the recommendations, ESMO recommendations for real-world data, shown here by Khalid earlier. So go ahead, and it will be a great success, I'm sure.
Yeah.
Thank you, Miriam, for highlighting this important topic.
I may add just one point in addition to what was said by my colleague Miriam. Yes, I agree. Real-world evidence is key, is very important. The only issue I faced myself when I want to publish retrospective studies in my setting is that we don't collect survival data in routine practice. You have a lot of loss to follow up, a lot of patients, we don't know their status, unfortunately. So it's very hard to predict survival. Sometimes you need information about some confounders, some comorbidities, etc. You have a lot of missing data. So we are not collecting good data from patients for this kind of research. So I hope that one day Africa will have electronic medical records that collect data correctly, and clinicians are encouraged to collect those data for future generations to do research on those data. So in my setting, we are facing that. We have a lot of missing data. So it's very hard to publish good retrospective studies, but it's very important as Miriam said.
Yes, thank you. Fully agree and encouraged to do that. But maybe we also have to do prospective ones, prospective collection from day one, which can be today. In a few years, we're going to have a very good and more better quality data, and we'll hopefully see more publications coming from different countries. So we'll have the controls. Well, because our time is running, I would like to thank our wonderful presenters for their interesting topics and raising the most important questions which clinicians or researchers are raising during their everyday practice. And hopefully we'll see you again in next webinars. Thanks a lot.
Great, Amalia. Thank you so much. I really appreciate to be moderating this session, because you remember all the beautiful times we had at ASCO last time. So it was really my dream to meet you again, at least online. So at least we are seeing you now online. I will be very happy to invite you again next time so we can do better. Thank you a lot also, Professor Miriam. Thanks a lot for sharing a lot of this great information about CDKA inhibitors. Hope to meet again soon to discuss about science. Do not forget that the country of Miriam, Tunisia, is organizing a great conference of the AORTIC, the annual meeting of the AORTIC in Hammamat. So I will be going there 2 days before. So at least I can have a swim in their nice beaches. And hopefully we can meet there all. There is Nice, as you know, in France, and there is Tunis, and Tunis is better.
Come to Tunis, yes.
Perfect.
Bye-bye. Have a good day.
See you.
Thank you.